Hi, I think I know most of you, but for those of you who I don't know, my name's Skip Campbell. I'm a transplant surgeon and the Chief Medical Officer at the University of Michigan. Our goal is always to provide the safest and highest quality of care possible for our patients. Unfortunately, despite our best intentions, we occasionally fall short of this goal. Miscommunication among caregivers is the most common cause of the harm we cause to our patient. To address this problem, we have instituted medical team training, which uses tools such as briefings and debriefings that are guided by the use of checklists to improve the quality and level of communication in the operating room. In order for these efforts to provide the best results for our patients, it is crucial that all operating room personnel participate fully in the use of these communication techniques. This video demonstrates how the pre-induction verification and the pre-incision timeout is to be conducted so that all those who work in the operating room environment will have a clear understanding of what is required. Finally, I'd be remiss in not explicitly stating that in the past our consistency in applying these tools has been less than desired and has contributed or caused to substandard patient care. I want to be perfectly clear, the conduct of both the pre-induction verification and pre-incision timeout briefings, aided by the use of the checklists as demonstrated in this video, is not optional. It is a requirement we are implementing to ensure the safest care possible for our patients. Failure to participate appropriately to give us the best chance of achieving this goal will not be tolerated. This is a team responsibility, and the entire team is responsible to make sure it is done in the best manner possible. Our patients deserve nothing less. Thanks for helping to continue to improve the safety and quality of care we provide to our patients.
The pre-induction verification is initiated and led by the faculty anesthesiologist or his or her designee. The anesthesiologist or designee, the circulator, and the faculty surgeon or designee are required to participate. During the pre-induction verification, all activity in the room needs to stop, and if the radio is on, it should be turned off or the volume lowered so that all team members can easily hear what is discussed.
How's it going?
Are you guys ready to start? We're going to start our pre-induction verification.
Sure.
Can we turn the music down, please? Thanks. So first we'll start with some introductions. I'm Melissa Burns. I'm the anesthesia resident.
I'm Joe Church. I'm the surgery resident.
Amanda Jackson, circulator.
Great. And now, Amanda, do you mind verifying the patient ID for us?
Sure can. We have Homer Simpson, date of birth 5/12/55. We are here today for arthroscopic surgery on the right knee. We have a surgical consent and our blood consent. At this time, there is no research consent. Is that correct?
I agree.
I agree as well.
And looking at the mark on our patient, the right knee is marked and matches the consent in our whiteboard.
I concur.
When a site mark is required, the mark must be visible after the prep and drape.
Me too.
Joe, do we need any special images displayed on the screen for you?
Yeah, can we get the right knee x-rays up, please?
Sure, they're right over there.
Perfect.
Reviewing the allergies, the patient is allergic to penicillin.
I agree. It's also up here on our whiteboard.
And Joe, we do have clindamycin. Is that okay with you?
That'd be perfect.
Great. As far as special drugs, do you want heparin for DVT prophylaxis?
No heparin's needed.
Okay. And then do you have any muscle relaxant requirements for this case?
She will need deep muscle relaxation.
Okay, so we'll aim for 0 out of 4 twitches on train of 4.
That's perfect.
Great. And Joe, do you need any special equipment for this case?
Nope.
And finally, what position would you like for this case?
Supine.
And any repositioning required?
No, there won't be any reposition.
Great. That completes our checklist.
Thanks.
During the pre-incision timeout, staff need to state their name, position, and level of experience with the procedure. The experience level is required so that other team members do not make assumptions during the case that could compromise patient safety.
Good afternoon. Are we ready to start? Can we turn down the radio? Okay, great. Why don't we go ahead and start with introductions. I'm John McGee. I'm the attending surgeon.
I'm Melissa Burns. I'm the CA3 anesthesia resident. I've done probably 3 of these, I would say, in the last 2 weeks.
Great. If everyone can say their experience too, that'd be fantastic.
I'm Joe Church. I'm a surgery resident. I've done several of these cases over the last month.
I'm Amanda Jackson. I'm the circulator. It's been a little bit since I've done one of these.
I'm Melissa Barbie. I'm a scrub tech, and I've been here for several years. I've done several of these cases.
Great. Amanda, if you have any concerns during the case, let us know. Just ask any questions.
All right, thank you.
Why don't we go ahead with the pre-incision checklist now, please?
Okay, we have Homer Simpson. His date of birth is 5/12/55. He is here for arthroscopic surgery on the right knee. We have the surgical consent and the blood consent. At this time, there is no research consent. Does this sound agreeable?
Yes, that looks correct.
Okay, looking at here, we have the right knee with the initials visible. Is this correct?
Yes, it's the right leg, and I can see the markings.
When a site mark is required, the mark must be visible after the prep and drape.
Do we have any allergies?
Yes, the patient is allergic to penicillin.
Good, that matches our whiteboard. Are the antibiotics in?
Yes, 600 milligrams of clindamycin is in.
Great, thank you.
Do we have a special drug plan at all?
Yes, we've decided that no heparin will be given, and for deep muscle relaxation with 0 to 4 twitches.
Okay, good.
We've discussed earlier that no special equipment is needed. Is this still true?
Yes, correct.
Are we expecting any specimens or explants?
Not for this case.
And is our EBL going to be greater than 500 milliliters?
No.
Good. Our patient is supine. The patient is safely strapped in. The pressure points are padded, and the SCDs are on.
Okay.
Are we going to reposition at
No.
all? Good. Let's review the fire risk procedures.
Okay.
At this time, the team reviews the fire risk checklist and discusses appropriate fire reduction mitigation strategies.
Okay, and we're ready for concerns?
Great. Melissa, what are your concerns?
Dr. McGee, can you just give me a heads up on when you want deep muscle relaxation and about how long you'll need it for?
I will.
Thank you.
Joe?
No concerns for the case.
I'm concerned that I've heard that the house is kind of full. Have we checked bed availability?
I heard the same thing, but haven't checked. Can you make a phone call?
Sure can.
Thanks.
I don't have any concerns for the case.
Okay, great.
All right, that completes our checklist. You can get started.
Great, thank you.
Note that the anesthesiologist and circulator are using checklists to prevent critical steps from inadvertently being skipped or missed.
Okay, everybody ready for pre-induction verification?
Yes.
Okay. Kevin Trepper, anesthesia faculty.
I'm Joe Church. I'm the surgery resident.
Amanda Jackson, circulator.
Melissa Burns, anesthesia resident.
Amanda, can you identify the patient?
Sure can. We have Marge Simpson. Date of birth is 10/1/55. Marge is here for a liver lobectomy. We have a surgical and blood consent with no research consent.
Great. Agreed? Could you check the surgical site marking?
Because it is an abdominal incision, we do not need to have the site marked.
Any diagnostic radiologic images, anything you need?
If we could actually get the liver MRI up on the monitor, that'd be helpful.
I can do that for you.
Thank you.
Okay, great. Okay, let's give some NSEF,
Wait, aren't we going to discuss allergies?
which she's not allergic to anything.
We still can't skip that step. It's important to discuss.
Okay.
No step should ever be skipped. Even if an item in the checklist does not have a positive response, it needs to be discussed and verified, as demonstrated in this example.
Okay, we should, you're correct. Let's go through the steps. So allergies, none?
None.
Checks up on the whiteboard, correct?
I agree.
Okay, good. NSEF?
ANSEP will be given.
Okay, that's great. Any special drugs, heparin?
No heparin's needed for the case.
Any muscle relaxant issues?
None.
Okay, great. So, any special equipment that you need?
We'll need the argon beam and the ultrasound in the room.
Okay, you get that?
Can do.
Okay.
Great.
Positioning, supine,
Supine is good.
no movement after that, supine the whole case?
Correct.
Great, okay.
Wonderful.
Ready to go? Okay, check complete, let's off to anesthesia.
All right.
The pre-incision timeout is initiated by the faculty surgeon who leads the introductions. The remainder of the pre-incision checklist is led by the circulator. If there haven't been any changes in staff since the pre-induction verification, it is acceptable for staff to only cover their experience level with the procedure during this introduction.
Okay. Great, good afternoon, everybody. We ready to get started?
Could you give us a few minutes to finish up with the sponges?
Sure, let me know when you're ready.
1, 2, 3, 4, 5.
Okay, and we're ready.
Great, thank you. So why don't we...
I gotta go next door, I'll be right back. Anything you need, give me a call, I'll be right
Okay.
back in.
Thanks, Kevin. All right, why don't we go ahead and get started with introductions. If everyone can say your name, what your position is, and how much experience you have, that'd be great. I'm John McGee, I'm the attending surgeon.
I'm Melissa Burns. I'm the CA3 anesthesia resident. I'd say I've done like 10 of these in the last 6 months.
I'm Joe Church. I'm the surgery resident. This is my 4th liver resection this month.
Amanda Jackson, circulator. It's been a while since I've done one.
Melissa Barbie, scrub tech, and I've done several of these cases.
Great, thank you guys. Amanda, if you have any questions during the case, please just let us know. Ask questions if you need to. All right,
do.
are we ready? Can we go ahead and now do the pre-incision checklist?
We sure can. We have Marge Simpson. Her date of birth is 10/1/55. She's here for a liver lobectomy. We have a surgical and blood consent with no research consent. Is this correct?
Correct.
I agree.
Looking at our side and site, I see that there is no mark required. Is this correct?
Correct, it's an upper abdominal incision.
If no surgical mark is required by UMHS policy, this step must still be covered when running through the checklist. The circulator should state that no mark is required, and the faculty surgeon must concur or non-concur. If the mark is required and is not visible at this stage of the surgery, all activity must stop, and the issue needs to be resolved by the faculty surgeon and faculty anesthesiologist.
Does the patient have any allergies?
No allergies.
And are antibiotics in?
Yeah, 2 grams of Ansep is in.
Great.
Do we have a special drug plan at all?
I discussed with Joe and we decided no heparin would need to be given and there's no considerations as far as muscle relaxation either.
Agreed, thanks.
Okay, as talked about earlier, for special equipment, we have argon and ultrasound in the room. Is there any other equipment you'll need?
Yeah, that should be enough.
And are we going to expect any specimens or explants?
Yes, there will be some specimens later in the case.
Later on, can you let me know how many so I can be prepared?
I will.
Perfect.
If specimens will be taken but the number or type are not known, it should be stated at this time. The number and type of specimens must be discussed again during the case.
And is our EBL going to be greater than 500?
Around 1,500.
Just so you know, Dr. McGee, I talked with Dr. Tremper before he stepped out, and the patient's crit is 32. Our target for threshold was 24.
I'd like the hematocrit to be more up towards 27.
Okay, so we'll set the range then somewhere between 24 to 27.
Okay,
Okay.
thanks.
And do we have blood available in the room?
Yes, we have 2 units of packed red blood cells.
Great.
Is that good?
Thanks.
Okay.
Great.
We have the patient supine, the SCDs are on. We have the safety belt on and all of the points are padded.
Great.
Is there any other repositioning needed?
No, should be supine the whole case.
Okay, let's review the fire risk.
Okay.
At this time, the team reviews the fire risk checklist and discusses appropriate fire reduction mitigation strategies.
Okay, we're ready for concerns.
Great.
Note that the faculty surgeon is asking an open-ended question, which requires more than a yes or no response.
Melissa, what are your concerns about this case?
We discussed EBL and the target threshold for transfusion. I have no other concerns.
Joe?
No concerns for the case.
Amanda?
I have no concerns.
Melissa?
I don't have any concerns for this case.
Okay. I have a concern during the operation when we're starting the transection through the liver. I'd like it if there was no changeover of staff once we start the transection.
Note that the faculty surgeon should be the last team member to speak so that other team members feel more comfortable bringing up their concerns.
Can you give us just 5 to 10 minutes heads up on that, and I think we can accommodate your request.
Okay.
Thank you.
I think that'll work for us as well. We'll make sure it happens.
Great, we'll do that. Thanks.
All right, this completes the checklist. You can begin.
Great, thank you.